Hi, this is Brian Kim. I'm going to share with you my second experience using the Aventis Hydrus Microstent. This is a little bit of a challenging case. This patient has a cataract, but also has endothelial disease. I'm going to do a ultra-thin DSEC on this patient as well. And this patient is a high myope. And so one of the things I noticed doing MIGS, even with the first generation eye stent, is the reduced scleral rigidity in these high myopes makes it a little bit of a challenge in passing these procedures when you're working in the trabecular meshwork. And so you're going to see I'm going to have similar struggles when I'm doing this Hydrus stent, and you'll be able to watch as I navigate through and try to get through this case. So I'm using a corneal marker, which will help me to center and size the rhexis. And then I make my paracentesis incision on the right side, and then you can see I'm making another incision. That's actually for my AC maintainer for the DSEC. And then this incision on the left side. Again, those are the incisions for the cataract surgery. I like to make sure that the incision is parallel to the iris plane, which allows me to create a nice corneal shelf, which allows me to achieve a self-sealing incision. That incision is for the boost and glide, so that when I pull the tissue in through the contralateral incision. This is intracameral lidocaine, and then some intracameral epinephrine. And this is some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, turn the eye towards me, and then I enter. This is the puncture style rhexis. I punctured the center of the capsule, push a little bit to the right to create a little bit of a tear, grabbing the right side of the tear, and then now I have my flap. I'm going around circumferentially, trying to stay within the confines of the corneal mark that I made, which will hopefully allow me to achieve a well-centered and sized rhexis. Rub some viscoelastic out. And this is the capsular fornix hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, decompress on the left side, which this patient, again, high myopes, there's quite a bit of zonular laxity, so it's a little bit more of a challenge to decompress. You can see that's why I'm trying to use the BSS to free up the anterior capsule surface as well. But again, yeah, this is all signs of zonular laxity in this high myope. So I lift the incision with a chopper, go in with irrigation off to minimize Descemet's trauma. I'm going to remove the surface epinuclear material. But before I do that, I'm lifting the iris off because it was causing a little bit of reverse pupillary block. Again, in these high myopes, that's pretty standard. I place the chopper under the rhexis edge contra-incisionally, the phaco tip vertically sub-incisionally, bisecting the lens in half. That's double chop, placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip and fracturing the right heminucleus. That is cross chop. Placing the chopper around that first quadrant, lifting it up. It's a little bit sticky. This is really not a dense lens here. Placing the chopper around the second quadrant, trying to fracture that piece. Trying to hook the pieces up. Again, the lens pieces seem to just be cheese wiring. This is a fairly soft lens. Finally able to hook the pieces up out of the bag and then start to emulsify the lens pieces. Trying to grab and lift up that second heminucleus. Quite a bit of a sticky lens. Using the chopper to try to mobilize that piece, which it comes out nicely. And then now I'm grabbing the epinucleus from anterior to posterior. Again, in these cases, the epinucleus is usually rather adherent to the capsular bag because I wasn't able to spin it very well. You have to be mindful of watching the posterior capsule, making sure the capsule is not adherent to the epinuclear material as you lift it up. So again, carefully lifting up that epinuclear material and emulsifying the pieces there. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. When you get to this point, it's better to just use the INA to remove the cortical material, especially since it was rather adherent to the capsular bag. So I switched to polish mode, polishing underneath the rexus edge. And again, with the weak zonules, and again, in these cases with zonular laxity and high myopes, you want to be really ginger with the capsular bag. You don't want to grab on it too tightly here. So you can see there's some fine wispy lens material. I'm just carefully trying to polish that stuff out. Pushing BSS into the subincisional capsular fornix. Of course, there's a bunch of stuff in there. Again, pretty typical, especially in this case where I had trouble rotating the lens after hydrodissection and a very adherent epinucleus to the capsular bag. I'm not surprised there's a lot of stuff there. So go ahead and push cohesive viscoelastic to fill the bag. And then I'm polishing under the rexus edge. And as I do this, thankfully, you can see there's a bunch of cortical material that's coming out from the subincisional fornix. And I'm also polishing off the lens epithelial cells. So whenever I'm doing a combined procedure with DSEC, I like to put in a 3-piece lens. I feel like there's better stiffness of the lens. It stays in the capsular bag plane, whereas with the 1-piece lens, it tends to not have as much support, and so the lens oftentimes will come up into the iris plane when you're doing the endothelial keratoplasty. So like a 3-piece lens in this situation. So I turn the bevel to the left, deliver the leading haptic in. I'm sweeping the trailing haptic to the right. And look what I did. The leading haptic did not go into the bag. And so, okay, that was unusual. That doesn't happen very often. And so I'm trying to use a 2-handed technique, a Sinskey and the Maltzman, to see if I can get that leading haptic into the bag. So I pull it down with the Sinskey and then release it with the Maltzman. All right, so that worked out okay. So I did a 2-handed technique with that. And then with the Sinskey here, I'm going to dial in the trailing haptic. All right, so now we're going to work on the Hydrus. So I fill the eye with some viscoelastic, make a stab incision, again, pointed towards the direction of where I'm going to have the Hydrus. I turn the eye away from me, put some viscoelastic on the cornea, and that's the Hydrus Microstent there. That's the handle. That's the back end right there. And you can see that little roller. That's the part that you're going to roll forward in order to advance the microstent. And then you can twirl that front side in any direction you want, depending upon your angle of approach. So you want it, again, angled just a little bit up, since you're not wanting to follow the direction of trabecular mesh. You want to actually have it go up a little bit, about 10 degrees, pointed a little bit towards the cornea. And so you'll see how and why I struggle a little bit with this case, starting from the get-go. And so I feel like I have a pretty good view here. But look what you start to notice. There's some heme in the interface. And so from the limbal vessels where I made my incision, and I believe it's from when I made the incision for the Hydrus, there's now blood coming in the interface Between the gonioprism and the cornea, the viscoelastic's got blood all over it. And so that's number one. Because of that, my view was really, really limited. And of course, in retrospect, it's really obvious. So I go ahead and flush that stuff off. Yeah, and so you can see that's where the incision was, and you see that it's bleeding from that spot. So rule number one, when you're trying to do these procedures, try not to make your incision so peripheral that it catches the conjunctival vessels. This patient's a high myope, wears contact lenses, and as we all know, high myopes who wear contacts tend to have some peripheral corneal vascularization, and so this was really a setup for me to struggle with this conjunctival bleeding. And once you have blood there, it really makes it a challenge. And see here, even when I move that blood, you can still see the blood coming. So I make my stab, and again, I feel pretty good about it, but again, the view is suspect. I see blood coming in and out of the view. And so I feel okay. I'm trying to advance, and as I advance, you see the stent pops down. So when it pops down, obviously, I'm not in. It's probably because maybe I'm too low on the TM. You're supposed to be on anterior TM when you make the stab. And again, you can see all that blood. It's mixing with the gonio. The gonio is not clear at all. And so I had to move the blood and start again. Of course, there's blood from where I did the procedure within the eye. And even though I removed the blood, now there's blood on the gonio interface between the gonial lens and the cornea, but there's also blood in the anterior chamber. And so my view is just really less than ideal. But I think I did a good stab. I'm pointing it up about 10 to 15 degrees, and then my view is terrible now. I still think I'm able to see what I'm doing. It's looking pretty good. But for whatever reason, I think I lost some confidence. I think I could have. I think that I was in the right place, but I withdrew. And I think that's simply because I had a terrible view. And as you can see, I'm really struggling to see what I'm doing. And it's primarily that blood that's between the gonial lens and the cornea. That limbal blood is just a really big problem. I did not think about, putting some topical vasoconstrictors like we do when we're doing, like LASIK. But I just started to just keep powering through and trying to do the best I can, even though the visibility is terrible. So I come out, remove all the blood again, and sweep all the blood out, put the gonioprism back on. Again, I'm trying to do the best that I can, placing the microstent back in the eye. And again, you can just see the blood is just kind of very smoky. You can see it's really all over the place. Even though I really tried to remove the blood, it's still there. So I go ahead and stab again, seeing if I can pass it. I start to advance the microstent. Let's see, is it going in the right direction? I think it's finally advancing. Okay, so I think it's in. So you saw it backed out and then pulled the roller back, and then pushing that tip against that little groove of the stent, and I'm trying to kind of finish off the placement of the microstent. So again, really challenging view. That interface really killed me, and that conjunctival vessels right there in this high myope really got me. I didn't really anticipate that. Really struggled with my view between the gonio lens and the cornea. That gonio material was getting mixed up with the blood, and it made really such a hazy view. Not to mention blood in the anterior chamber. Every time you stab and you don't really get it in place, there's just heme in the anterior chamber as well. But thankfully, everything looks like it's okay. I'm talking to Nisha, and she's telling me she feels really good about the positioning. And so there it is. That's the stent. And so, really, what did I learn? I think in high myopes, you have reduced scleral rigidity. Sometimes when you're trying to make that stab, you might not get it in the right place because as you're pushing, you don't have enough counter resistance. And so when you're pushing through, the eye just kind of moves away from you because of that reduced scleral rigidity in the high myopes. And so it's important to make sure you stab properly, angle up, point it towards anterior TM, and then when you start to advance the roller, and you feel like you're in place, then you want to level out and go. But for me, the biggest issue was the view, and that really sabotaged everything. Try not to make your incision so peripheral that you catch the conjunctival vessels. And if you see any blood, that could really ruin you and make it a lot more challenging, like it did in this case. But thankfully, the patient did well, and we went and proceeded with the endothelial keratoplasty, and the patient did great. So I hope this was helpful to you, and I thank you for your attention.